so much. I really appreciate our NuSmile team. For those of you that aren't aware, there's a lot of work that goes into preparing for these and sending out CE and advertising. So I really appreciate NuSmile's dedication to intraosseous delivery of local anesthesia. So welcome everyone. Either you're watching this live this evening or you're watching this in the future. And on behalf of myself, Joshua Solomon, and on behalf of NuSmile Tech, I want to welcome you and bienvenue on behalf of Dental High Tech in France. And tonight we're going to focus on becoming a master of the intraosseous delivery of local anesthesia for the pediatric dentist. And for those of you that aren't aware, this is really a two-part webinar that's continuously ongoing. So this webinar will be recorded. So in the future, if you're driving to work and you want to learn more, refresh all the little bits of information that we're going to teach you tonight, these will be recorded for you in the future. And so I do want to recognize Dr. Ann Bynum, Dr. Megan, and Dr. Miranda, who are teaching the introductory course, but also later in the year, Dr. Bynum, Dr. Ann will hop in and take over some of the mastering. And so we really do this as a team. And down there is the website for NuSmile. So all of these webinars recorded, and you've got them at your disposal in the future. Just to tell you a little bit about me, I'm a second-generation pediatric dentist. So I am now 21 years into practice, and I'm a diplomat and a fellow. Along with my pediatric dental office, about a year ago, I opened the BioClear Pediatric Training Center. And the goal of my centers is to offer content like this, is to offer our pediatric dental colleagues the ability to have the best CE possible. And I have a long history with NuSmile. I actually did my residency in Houston, where NuSmile is based. And a lot of the courses that I teach are not only intraosseous local anesthesia like this, it is aesthetic restoration of anterior and posterior teeth. I'm one of those people that I like accounting and I like financial analysis of the dental practice. So one of the things I teach, photography, I use a microscope almost on a daily basis, and you can use higher magnification or microscope in pediatric dentistry, I promise. As I mentioned, about a year ago, I moved into a new office, and we've got about 6,000 square feet, 13 chairs, and numerous times during the year, we turn the practice over to the Learning Center, and you guys are all welcome to come out. There is my contact information. So if you use your phone and take that QR code there, I promise you, if you reach out to me, I will get back to you. If you find that you reach out to me and I don't get you right away, I apologize. Give it a day and write me again and say, hey, I had some questions. Please write me back. I promise I will reach out to you. And there's my lovely Flammy, who's always patient when I'm doing these webinars or teaching courses. But I am reachable, so please reach out to me if you have questions in the future. Just a couple pictures of my facility. So we wanted to keep everything really open and bright. And I wanted, as far as for the doctor and the associates and the assistants, to have all the computer screens for digital charting. Everything's in front. We went with just primary colors and really keep everything open. As I mentioned, I love teaching. Many times a year, we have large groups of pediatric dentists that come through, and we convert the office into a learning center. And I'll show you a photo later on, but actually the SOAN I have built in to, the Sleeper One I have built into one of these operatories, and you can really do a nice job running cables and making everything clean. So before we get rolling tonight, it'll be helpful for all of us, the whole team at NuSmile, to get an idea of what your background is with local anesthesia, with intraosseous delivery. So Chris, do you want to start that for us?
Yeah, so the poll is live, everybody. It's just 4 questions. We have about 75% of the attendees have already participated, so we got some good results here. It looks like majority are SOAN users over Sleeper One. Apologize for the Santa question. That was a copy and paste issue on my end, so I apologize. But about 52 of the attendees do not own a SOAN or Sleeper One yet.
Okay.
They are using it on about 19% are using it on all of their patients, with about 24% falling back on traditional syringe. Good balance of using the devices for entering from the lingual instead of the buccal. So all across the board there, it's about even. And then preferred delivery method for those that do have the device is cruise. So it's a 18% cruise, 16% use drive. For anybody that doesn't know what that means, 66% said not sure. We'll definitely be covering that tonight. So thanks everybody
Good mix.
for
Thank you.
responding to that.
Yeah, that really helps us. And I'm hoping those people that are only partially using their Sew-In or Sleeper One, I would love if I can get to everybody by the end of this webinar and convince you to take that to close to 100%, but we'll see by the end of this. So just briefly, I'll show my age a little bit. I graduated my residency in 03, and that's actually where I was introduced to NuSmile, because again, I went to University of Houston, and NuSmile is right there. I was very lucky to visit just a little bit ago. And as all of you know, NuSmile makes a large selection of restorative materials specifically for pediatric dentists. And as of 23, thankfully, I'm very happy that Sew-In Sleeper One came on board, and we're going to really dive into the details about that tonight. Just a few disclaimers. I am a key opinion leader for NuSmile and Dental High Tech. What does that mean? That means that they provide funding when I speak. I get products that I get to test, and I get to be an ambassador for these products. But the one thing I wanted to say tonight is I specifically asked not to receive any compensation for this webinar. So, myself and the team that I work with, we spent quite weeks and weeks preparing for this. And for the webinar tonight, I specifically asked not to receive any compensation. That in lieu of to be donated to a charity of NuSmile's my choice later on. And the reason why I did that is I did not want to have any financial entanglement for this webinar tonight. And the reason for that really is I truly believe that these devices should be the standard of care in delivering local anesthesia to children, right? When we talk about the idea of standard of care, what is that? It's really the accepted method of doing something where the average practitioner says, yes, that's the bare minimum of how you should perform a procedure, or you should treat your patient. And I will tell you that I don't want to practice at the standard of care. I want to elevate my clinical acumen, my knowledge base to as high as possible. And I really do try on a daily basis to strive to be the best clinician. And all 200 of you that registered, I know that you feel the same way. And so what I ask you to do is watch this webinar, maybe listen to it again, and I want you to become an expert. If you don't feel 100% that you have these devices mastered, watch this webinar, reach out to us, and then also be an advocate for its use in the future. So let's talk about why that I feel like these devices should be the standard of care in pediatric dentistry. And number one, when we say pain-free, I have some quotations around that because I don't think there's any procedure that you can do in the mouth where you can guarantee 100% pain-free. I will tell you that in my experience, 8 out of 10, or really more 9 out of 10 patients do not respond. That means I can give stage 1, I can enter into the bone, I can give that intraosseous injection, and 8 out of 10, or more likely 9 out of 10 patients do not respond. Now, we will talk later on about the difference between pain and pressure. We know that in the in the intraosseous bone, in that there are pressure receptors, right? And so sometimes our patients will feel pressure, but the chance of one of these injections, if done properly, having pain is very low. And so we need to determine, is our patient having pain or pressure? Not having to back up my injection with a supplemental palatal or supplemental lingual or a PDL makes everybody happy. I only want to give one injection. Maybe I need to give a second site, few percentage of the time, but most of the time I'm giving one intraosseous injection, and that patient is profoundly numb. All right. Here's the big one, is no collateral numbness. Unfortunately, in my career, I've had way too many patients that have bit their tongue or their lip. I see stories online. I haven't had one of my kids wind up in the ED, but there are posts all the time about patients showing up to the ED because they didn't check in with their dentist, and the emergency room doctor not knowing, thinking that it's an infection, write antibiotics or do a hospital administration. And it will tell you, if you perform this procedure properly, you should not have collateral numbness. That means every single intraosseous injection that I give, for every procedure, my patient, and most of the time, unless it's like an extraction, they can eat and drink right away. They're not going back to school or home with a numb lip or a numb cheek. And I will tell you that the behavior that I've seen out of my patients has improved greatly, because if they're going to be okay, initially with that injection, we forget about that. A lot of times children are just uncomfortable because their lip and their tongue feels big. And so we may have that appointment may not go well a few minutes in after they start feeling that numb lip or numb tongue, and we just don't have that anymore. This idea of the midline and the mandible is gone. We don't have to worry about that anymore. And so I would typically, my treatment choices, I don't like to numb if I'm going to give a block on both sides of the mouth. And that's difficult because that may mean, if that child has decay on just their mandibular teeth on both sides, they may need 2 appointments. And now those 2 appointments become one. And I really diminish the amount of appointments that I need for restorative dentistry. We know that even for that cooperative child, the more appointments you have, the cooperation can go down every single visit. And just from a business standpoint, having less visits is better. It's better for the parent. They have less time off work and less time that they need to take away from school. One of the magics of intraosseous delivery of local anesthesia is when you are done, you can immediately start your restoration or your extraction. This took me a little bit of time before I truly believed it, because I'm used to giving a block and going to do some checks and then coming back. And the first few times that I gave an intraosseous injection, I still waited a little bit. But I will tell you now, once that needle comes out and you are done injecting and you see blanching, you know that that patient is numb. You can start your pulp, you can start your extractions. Literally, you can start right away. For those of you that use an isolite, differences now is I used to give my local and then wait till they're numb and then we put the isolite in. One great thing you can do is just start with the isolite, have it in place. It gives you good retraction. You have less of a chance of patient tasting your local. You can put your isolite in and go ahead and give your local and then just start immediately. And not having to take that isolate in and out or introduce it later on can make a big difference in the speed of your delivery of treatment. And again, we just give our local, we make sure that we deliver the correct amount, correct location, and we just start right away. And I will tell you that the cooperation level I have had in my patients has greatly increased. In my training, we did a lot of oral and IV sedation, and I came out with an IV anesthesia permit, and we do GA in my office. And I will tell you, since I have integrated this method of giving local anesthesia, the amount of sedation that I need to perform has dramatically decreased. And it's less stress for the parent, it's less stress for my staff, and it's obviously less stress for our children. And then those post-operative side effects about a numb lip or numb tongue just goes away. And anytime I can condense appointments, I make things better for my business. I make things better for that patient and for that parent. And most importantly, to those of you that are new or doing startups, when you're thinking about your marketing, there's nothing better than internal marketing. And if you have a parent that is telling their friends or their colleagues that their child came in for restorative treatment in your office, the child didn't even react to being numb, they weren't numb afterwards, they had a great restorative visit, those are the type of parents that are going to continuously talk about your practice. I will discuss this case a little bit later on today, but I will tell you, it's this patient, this 8-year-old, where after I finished this procedure, I was sold and I knew that I was not going to pick up a standard syringe again. I will tell you without equivocation that I have not picked up a standard syringe for a patient under 14 since I brought in the sew in and sleeper one in my practice. I've not picked one up. And because the magic here, and we'll talk about this in detail later on, is you can give one painless intraosseous injection there between O and P. And I gave this patient a half a carpule of anesthetic, and they were profoundly numb, and I extracted NOPQ without sensation from the patient. They did not literally move the entire time. This was an anxious patient. Again, we'll talk about it, but it was this alone. Even if you don't do anything else, but you use these devices for local anesthesia delivery in the anterior for extractions, it's worth it. It's definitely worth it. And this is the big one, right? What we need to remember is that when we give a local infiltration, not only is that local diffusing through the cortical plate into the cancellous bone, it's also going to areas that we don't want, right? It doesn't make sense to me now that I utilize these devices. If I think about if I need my finger numb to do a block of the elbow, it just doesn't make sense. But that's what we were doing, right? We were taking a bolus of anesthetic, we're delivering it by the intraalveolar nerve, and we were waiting for that nerve to trace along the mandible to get all those areas numb. And unfortunately, not only the teeth get numb, but the lip and tongue. And I have not had, thank goodness, one patient with collateral numbness since I've been using these devices. Now, little reminder here, I know some of you delegated to your staff to do the onboard training. I don't want to tell Chris and team on that, but for those of you that have not, that own these devices that have not finished your onboard training, please do. That's going to go over the basics and all of the basic information that you need to know. We're going to go into way more detail tonight about how these units work and actually giving these injections. But please, please, please finish your onboard training. There's more help for you than you would ever need. You can set up that virtual meeting and with one-on-one help. And if you complete this onboarding, which everybody needs to, NuSmile will graciously send you a box of needles free of charge. Okay. And just so to prove everybody that I did it, here's my onboarding. Doesn't take very long, and they make it very easy. You just click through some slides. You're going to watch some videos, fill out some information, and once this is complete, again, they'll send you the free box of needles. I'm excited to announce that there are these brochures available to you now for your practice. Although I explain the So Inner Sleeper 1 to parents, it's really nice to have these brochures. You can just put them right in your operatories, and you can either before the appointment or during the day of the appointment, you can have them out and give them to parents. So these are now available for sale. You can get them on NuSmile's website. If you have any questions, just reach out to NuSmile. But this is a really well done brochure. And what I appreciated the information, this is crowdsourced. So this went out to everyone that's on the So In Sleeper 1 Facebook group and for suggestions. And this really has most up-to-date information for parents and explains these injections a way that parents can understand. I'm going to show this slide at the end as well, but if you have questions, if you're having tech problems, if you have a question just on the use, if it's a clinical question, feel free to reach out to me or any of the doctors that are associated with NuSmile. But Chris and Jordan, Aaron, they're very reachable. And if you do scan that QR code, you can schedule a free demo if you're new to these devices. But take a screen capture, take your phone out. These resources are all available. Their information is available online, but everyone is here to help you. I really do encourage everyone, if you have these units, you're thinking about getting these units, to join the Facebook group. The Facebook group is unbelievably supportive. There is a group of people that are new to these devices. There's people that are expert users. And I have never seen more than maybe Chris, a half an hour before after somebody posts a question where there's not 3 or 4 people jumping. It's almost too much with people that want to help, right? So if you're having a problem, and people answer this after hours on weekends, so you have questions, you need help, someone will help you, I promise you, on the group. All right, so what are we going to talk about tonight? We're going to go over the basics and then the kind of banal minutia of these devices and how they work and options. We're going to go over the basics of the 3 parts of the intraosseous injection. One slide I think is important that I want to share with you tonight are my 4 Ps. My 4 Ps are my mantra that I say, literally every time before I give an intraosseous injection. And it's just to make sure that I've crossed my T's and dotted my I's, and I'm totally prepared to give that intraosseous injection to the patient. We're going to talk about the Epitech needles and how they are different, why they're special, and why we need to use those needles for this technique. We're going to go again over the basics of how you give this injection in the first place. For those of you are new, it can seem a little bit daunting, but I will tell you, it is very much not different than what you've been doing your entire careers. We'll talk a little bit about local anesthesia and chemistry. We're going to talk some about positioning, and then we'll go through the common places where we give these injections, and then we're going to go over some cases to really wrap things up, and so everybody understands where you give the injection, why you give it in a certain place. One of the questions that we had that everyone's asking is how much volume, how much local anesthetic. Number one, what local anesthetic you use, and number two, how much local that you give in each site. Now, some of that's doctor preference, but I will give you, my suggestions and personally what I do, and we'll go into that detail. What I want everyone to understand is the concept of intraosseous delivery of local anesthesia. It's not new. Although these devices have been around for, I believe, 25 years, the concept of passing that needle through the cortical plate and delivering in that vessel, in the cancellous bone, and then having the entire, both the tooth and all the anatomy that surrounds that is not new. This is from the 1900s. I know as a practitioner, I'm worried a little bit about things that are new, right? I don't want to be the first person on the block. I don't want to have a problem with something. And then people say, well, you just jumped on this too early. This concept has been around a very long time, 1906, right? If we look at the worldwide distribution of these units, as I said, Dental High Tech is out of France, and you see that there's a huge amount of use of these units. In the United States, really, we were one of the, I believe, one of the last on the map here to get these units. And I just found out tonight that the only state where a doctor does not have a sleeper one or sew-in is Wyoming. So if there's anybody on the webinar from Wyoming, let's have you pick up a unit, and then we can say we're 100% at every single state. I can also tell you that California, where I am, we have the largest number of units in use. We're a big state, a lot of pediatric dentists. So this is not new. These devices are not new. They're new to us as pediatric dentists since 2003, but this technology has been around for a long time. There is a huge number of internationally known both general dentists and specialists that use these devices. The stars on the picture here, I want to really thank both Dr. Prin and Anne and Paul and Patrick and Sarah. What I did with this webinar is and then also Eric Hans and Brian Richards, I was able to poll everyone. I spent probably about an hour with all of them. These are all power users. And I said, okay, tell me everything that you do with your units, where you give the local, how much you give for each patient. Tell me all your little tips and tricks, because what I wanted to do is take our collective of doctors that are very experienced using these units and collate all that information. And that's really, I'm going to share all with you tonight. And we'll know by the end of this that there's not some trick or some tip that likely we have not covered. And again, I want to thank Eric Hans, who was the one who introduced me to these units. And he spent time with me as well, going through the webinar and giving me some of his suggestions. So I want to personally thank him as well. All right. This has come up in our Facebook group, and it's come up on IPEDO, is what are the differences of these units compared to some of the others on the market? Here's the important thing. The sew-in and Sleeper One is the only digital device that has a special needle and is designed for intraosseous anesthesia. Okay. Some of these other units that are digital, they are not designed for intraosseous anesthesia, and that's a problem. Yes, could you use one of these units to pop through the bone? Most likely, but the issue is they're not designed for the delivery of intraosseous anesthesia. Both the Sleeper One and sew-in, the technology inside, are constantly measuring pressures. and they are designed to keep you safe. The thing you need to realize with both the Sleeper One and the SOAN is it will keep you out of trouble. It won't let you give anesthesia at too high of a pressure. It will shut off the unit and it will actually retract the plunger. So please, if you have colleagues that say, oh, well, I want to buy a unit that's $300 for eBay, it is not designed or licensed or certified for the intraosseous delivery of local anesthesia. In my career in 20 years, I've seen a huge change in the technology of how we treat patients. I went from being in a dark room and opening up X-rays to having digital X-rays, and seen so many other advances in the materials we use. But until I got the Sleeper One and the SOAN, I didn't even think about making a change in how I deliver my local anesthetic. That's just the way we did this, and it hasn't changed. If you look at this kit from the 1900s, it pretty much looks like what most docs are doing today. But now is a change. Okay? Now we have devices that are specifically designed for the delivery of intraosseous anesthesia. So what are the differences? And I think this is important to go over because not everybody understands this. These will both deliver appropriate and safe dosages of local anesthetic intraosseously. Okay. The needles that are used for both of these units are exactly the same. They're both able to give the same local anesthetic in that carpule, right? The main difference obviously is one is corded, so the Sleeper One has a cord, and the SOAN is portable. I have both in my office. I'll show you a picture in a minute. And Chris and I were talking about this before the webinar today, and I had asked him, well, what do you find most doctors prefer? And it really comes down to personal preference. If you are using these devices on a daily basis and you have more than one operatory that you're delivering care, I really would encourage you to buy several units. Okay, and there's a couple of reasons for that. And I don't make anything by buying more of these, but many offices start with one SOAN because it's portable. I do worry about carrying that SOAN from operatory to operatory, right? You've got to pick up the SOAN, you've got to pick up the pedal, you need to make sure you have the cartridges, you need to make sure that you got everything ready to go. And in a busy practice, I worry a little bit about taking that to operatory. Still totally fine, you can do that, but just know, you've got to gather all those things and hopefully it doesn't get dropped. Personally, there's things I like about both units. I would say from a comfort standpoint, I prefer the Sleeper One. I find that the weight is a little bit more balanced, but that really is up to you. There are some more options as far as customization with the SOAN, but most people, once they set their initial selections, they don't make a change whatsoever. So it really is up to you. Cost-wise, Sleeper One is a little less. In the grand scheme of things, not by much. So I would say if you're going to buy one unit and you plan on at first taking it for operatory and operatory, obviously you're going to pick the SOAN. If you're going to buy multiple units or at one time or then add, if you have one or two operatories that you're constantly using, you may want to consider the Sleeper One, but that really is up to you. Cost-wise, I think this is important to go over this, so I asked for current numbers. So right now, the SOAN, which is the portable unit again, it's $2,950. And if you buy multiple units, that price comes down, okay? And then the Sleeper One there on the right, again, it's corded, doesn't have a battery. It's a little less money. And so that may be something that you're thinking about. Like I said, my two main operatories, I have one of each, and there are things that I like about each one of them. Now, you may have not known this, but when you bought one of these, it came with a manual, right? If I have a device in my office that I'm using every single day, I need to read the manual. I really encourage you. I'm going to go through some highlights for both of these units, but if you can't find your manual or got thrown away, it's available online. Just go to NuSmile's website. You can find it on the website. You can also find it on the onboarding, but there is a very, very well done manual for both of these units that goes into all the detail that you need to know. All right. So there's our SOAN. This is the portable unit. Again, the needle that you're going to use, and in pediatrics, we're using the 9mm green needle there most of the time. It's going to be the same for both units. So you see, you have the sew-in itself, then the battery charger. We'll go over the needles and which ones we use and which ones that you're most frequently going to use. You have the cartridges there, and that's what holds that carpule of anesthetic and the foot pedal, and it does not come with a koala bear. I'm very sorry. All right, so this comes again from the manual from the sew-in. There's a couple things that I want you to see here. All right, number one is the pedal. The pedal has two different buttons there that will engage and deliver that local anesthetic. The small button is for the drop by drop, and that's that first stage. So when we give our tissue anesthetic to numb both the soft tissue and the periosteum, we're using the small pedal. Then the large pedal is to actually deliver the majority of that local anesthetic. There are several buttons on this unit. So of course there's on and off, there's the light for the battery, and then there's also the resistance lights. So those 4 lights there are important that you monitor as you're giving the injection. There was a post the other day with a doctor, and they were mentioning that it was delivering very slowly, and someone had asked, well, what happening with stats lights? And they said, I don't know, I had to turn the other direction. You need to have the sew-in tilted towards you so you can at least see the lights. For some reason, if you go to give the injection and you didn't have everything aligned perfectly, you didn't rotate your needle, you can ask your staff to let you know what the lights look like, but you really need to set this up, and we'll talk about this so you can actually see those buttons. Now, on the pedal itself, besides the high and low speed, those 2 buttons, there is, the delivery local anesthetic with the small and large pedal. There is the high and low button. We'll talk about that in a minute, the upper right, and then aspiration. So once you're done delivering your local anesthetic, if we want to remove that, to retract the plunger and unscrew the container, remove the local anesthetic, we're going to hit that button. Chris made a really good point today that I did not think of. When your staff hits that triangle button on the unit itself, that will retract the hub. But if you hold it down, it's going to get you into the settings menu. So if all of a sudden a setting is changing on your unit and you don't know why and you think it happened automatically, it comes from your assistant instead of just hitting that button once, holding that down. Okay. So once you set whatever your preferences are, it should not change. But if all of a sudden something changes, you may need to look at if they are, holding down that button. Here's one important point. We know that sew-in has the 2 delivery buttons, the small button and the large button. If your foot is engaged with both buttons, the drop by drop is always going to win. And the reason why I say that and why it's important, and this happens to me once in a while, is I'll be giving my intraosseous injection, and I notice, why is this being so slow for so long? Well, I had my foot on both pedals. Okay, so if it's slow, just reposition your foot, come off a little bit, and then make sure that you're only pressing that large button. All right. Now with the sew-in, there are some options. I would suggest not touching all of these. Okay. We can change the sound. We can make it louder or quieter. The quantity pre-selection, you can set this so it will give a 1/4 carp or a 1/2 carp or 3/4 or a full. That's really up to you. That's a user-defined measurement. I personally don't use that, but you can. The time before shutdown, we'll talk about that just in a minute. That's something that I said at the beginning and I leave be. The adjustment of injection speeds. That is something that we're going to talk about, and it's going to make a difference on what type of injection you're giving. And then cruise and drive. This is an important point, and I really want to make sure everybody understands what's the difference between cruise and drive. So one thing I want to make clear for everybody is the shutdown time. By default, okay, the standby time is 10 minutes. So what does that mean? Is if you charge this fully and you have it set as your standby for 10 minutes, you can give 30 full carps before you run out of power, right? And then it just changes from there. So if you have the standby time at 2 minutes, meaning after 2 minutes, this will shut off, you can give 50 cartwheels. It's really up to you. But the important thing here is, because I know a few docs had asked this question in previous webinars, it is okay to leave in the charger all day. All right. There are some devices that we use in the dental office that should not sit on the charger all day. It's completely safe to do so. All right. Now, here's the big point that I want to make. If you look there where it says option 1 default, option 2, this is the adjustment of the injection pedal. So by default, your unit comes in cruise mode. And what is cruise mode? Cruise mode is if you press the large pedal, it will start the injection, and then it will keep going until that defined amount of local anesthetic is given. And then if you press it again, then it'll stop and you'll hear 2 beeps. So again, by default, it's going to come in cruise mode and it's going to deliver a full carpule. Now, you don't have to deliver that full carpule. If you give a quarter carpule and you click the large button again, it will stop. And then drive mode, thank you, Chris, he explained this. I was trying to come up with a way for dentists to understand, and this completely makes sense. It's just like your restat for your handpiece. So when you press that large pedal, it's going to keep on delivering it local anesthetic until you let go. Personally, I leave mine on drive. It really is up to you. I think that's doctor preference. Some people choose to change this over time. They may start on a cruise mode and then decide to change it to drive. I would just make sure that all the doctors that are using this in your practice and the hygienists all just pick a mode and leave it. There are some people in some, they have multiple SOANs and they have different settings, and that's really up to you. But again, cruise or drive. And again, on your unit, that triangle to retract the plunger, just remember you need to hit just once, or you can use your foot pedal to retract. All right. On the foot pedal itself, you see that metal piece, that actually is an antenna that needs to be attached. Right? You have 2 options for colors. B for blue, or pink is the other mode. Now, the way I remember this is B for babies or B for bone. You need to make sure for that intraosseous injection, you're going to leave it on blue. I have seen where I was training someone on this and they used it part of the day and they came back and they made a mistake and they accidentally clicked the pink button. That is only for infiltration and to give a local infiltration. So vast majority of the time, the unit's going to stay on blue. And if you decide, you can give a block with the SOAN. If you want to use a different needle and use this like your typical syringe, you can do that. And you're just going to make sure that you put it in that pink mode. So that upper right, you're going to click either pink or blue, but most of the time in my hands, 95% of the time or more, we're leaving on blue. Now, one of the nice things about this unit is it will aspirate. So if you decide to use the SOAN for a traditional block, then it has to be on pink. You have to make sure that you give at least 1/8 of a carpule, but you can click that aspiration button and it will aspirate for you to safely give that block. Okay. Sleeper 1. So the sleeper 1, again, it's up to you which unit that you want to use. I think in my hands, it's a little bit more comfortable. I could make an argument for both, but if I had to pick one, I think for me, it may be the sleeper 1. But again, you're not going to move that from operatory to operatory. There are really no individual settings for the sleeper 1. Well, there's one, but it's the speed, and our suggestion is do not change that. Just leave the algorithm as is. All right. And the top pedal there in green, that's drop by drop. And pedal 2, the larger pedal, is to deliver your local anesthetic. And it's the same thing. If you were to step on both, the small pedal wins. If you're delivering local anesthetic, very slow. If you see that plunger just barely moving and there's no resistance lights that are showing up, you're probably stepping on both pedals. One thing that's important to know here is if you look at the light for the sleeper 1, you can see it circumferentially around the unit. And I do like that because I'm not worried about the orientation that I'm holding this. The only thing I'm worried about is the direction of the D for the needle there, and we're going to talk about that. But you can circumferentially see that light. I'm not worried about having to rotate in order to see if it's blinking, and that would be indicative that there is some resistance there. All right, and you can do the same thing here. Now, this also has the orange mode for to give an infiltration, and just remember that you've got to have it in that orange mode in order to be able to give a block, and it will retract that plunger for aspiration, but you still have to give at least an 1/8 of a cartridge. Okay, so again, up to you what you want to do. My suggestion is busy practice. You may want to pick up both or have 2 sleeper ones or 2 SOANs. That's really up to you. This is one of my operatories, and what we did here is very easily just run the power cable for the sleeper one through my unit. And the nice thing, it's always there ready to go, super clean. And this, I did it myself. It just runs through the arm there, and then our pedals on the floor. These units do come with a mount. And the one point I want to make is you see that the SOAN is vertical there. Excuse me, the sleeper one is vertical there. That's okay if you don't have local anesthetic in your unit. But if you have it sitting in the holder, what you do want to do is have this on an angle. So we're actually going to put it in backwards, so upside down compared to how I had it before. And the reason for that is in the very rare instance that there's a leak or some, your carpule of local anesthetic somehow breaks, that you don't have any of that fluid that's dripping back into your unit. So when you're storing this and it's ready to go there, you do want to have it at an angulation and have it upside down. Canisters. This comes up a lot. So we know that these canisters, they go through your autoclave. Each one's about $20. It will come with 5 for either the SOAN or sleeper one. We do want to make sure, don't ask Larry why we have this slide in here, why we have to remind you that they're sterilizable. They are not disposable. Don't throw these things away. Each canister will have a lifespan of about 50 sterilization cycles. And I find that's not a number that the manufacturer just made up. I find that that's actually very accurate. And you should see a little blue color in it, okay? And that blue coloration will allow you to see if you're starting to having little bubbles or cracks. Remember, these are not something that you can keep for years and years. Again, you get about 50 sterilization cycles with them. And when you start seeing cracking or bubbling, and I'll show you a slide in a minute, you want to make sure that you toss that one and put a new unit into circulation or pick up a new pack from NuSmile. I want to thank Dr. Paul Bond here. We had a hard time because I have 2 units. Some of my assistants were having a hard time remembering the cartridges are different sizes. And so his little reminder here, SOAN has 4 letters like the word long. So the longer canister, the taller canister there is for the SOAN, and the shorter one is for the sleeper one. What we also do in my practice is we just have little sterilization tape, and we've cut a small piece of sterilization tape, and each room has a color, and that way they know. All right. These are examples of when you need to start thinking about replacing that cartridge. If you choose to not replace it, you have to remember this is under a little bit of pressure, and we don't want it to break on you, right? These are plastic. So if you don't follow manufacturer guidelines and you decide to hold on to these far past the 50 cycles, you do have the possibility of one breaking. I haven't seen that in my hands, but we're keeping an eye on these. So our sterilization tech knows if they start to see some of these bubbles. What I would recommend is at first, you be the one as the doctor to make the decision of when to throw this away and replace it. But after time, my staff knows they're starting to see some streaking, they're starting to see some bubbles and some cracking. It's time to replace it. All right. So we're going to transition from the hardware and actually how to use these units to the actual delivery of intraosseous local anesthesia. So really, how do we be effective? What I want everyone to know is that this is not that much different than using your standard syringe. Okay. I at first was really worried. I wanted to know every little detail, and I called Eric and said, tell me about the D and how am I supposed to hold my hands. And I really thought that I'd have to learn this whole new thing. You know what? If you can have a 4-year-old in your chair and give them a block and get successfully through that procedure and get successfully through your operative, you can do this, I promise you. So number one, we need to know what the appropriate anesthetic is. That comes up a lot. I know the team at NuSmile gets questions about, well, which local do we use? and how much of that local do we give, and I'll discuss that today. And we want to know that I want my life to be easy when I'm doing restorative dentistry, right? It's hard enough taking care of children. It's hard enough dealing with parents sometimes. So if I can keep my patient calm, if I can be calm, that's a good day. And really the key for intraosseous anesthesia is we want to inject that local, whichever local that we're going to choose to use, as close to the target. What's our target? Most of the time, if we're using this to treat teeth, it's going to be the apex of the tooth itself, right? I mentioned earlier that now that I use these units, it seems so foreign to me to take a standard syringe and a long needle on a 4-year-old or 6-year-old, 10-year-old, and to give them a block. I can't wrap my head around doing that anymore because I'm now able to give that bolus of local anesthetic as close to the apex of the tooth as possible. And if you see there from the diagram, we are going to be using a needle. We're going to go past the soft tissue. We're going to go past the cortical plate, and we're going to inject that bolus of our local anesthetic into this bathtub, right? We're going to bathe these teeth in our local anesthetic. And once we're done, we will be profoundly numb. Anything that touches that bathtub, that containment vessel, so the tissue and the tooth, both buccal and lingual or palatal, will be profoundly anesthetized. And I want to get as much of that local directly close to the apex as much as possible. So let's show you just a video here, a diagram, an animation of how we use this unit. Now, the unit that is in this video is a little different than we have here in the US, but we're initially going to come in at about a 15-degree angle, and this first step is just to numb that papilla. Maybe about a 4-millimeter circle is all we need. We're going to numb the soft tissue, and we're going to just give that delivery superior to the periosteum. Once that papillary triangle there is numb, once the periosteal tissue is numb, we're going to pass our needle through the cortical plate, and we're going to deliver a bolus of local anesthetic into the cancellous bone. So let's see what this looks like in the mouth. Thank you, Paul Bond, for this video. These videos are not easy to get. You did a great job here. So we're going to break this into 3 different steps. All right. What I want you to notice is that D. That D is facing out, away from the tissue. That's job number 1. I need to have that D always facing away from the tissue. We're going to come in at about a 15-degree angle. Now, his angle here may be a little steep, but he needed, actually, it's pretty close to perfect, but just know that in order to shoot this video, he wanted to open things up a little bit so you could see properly. So we're going to give this step 1, and we enter into the tissue. And this takes, 7 to 10 seconds or so. And we're delivering just drop by drop local anesthetic. And we're numbing the soft tissue all the way down to the periosteum. We're not touching the periosteum. The periosteum is highly innervated. We don't want to touch that, but this is just in order to be able to easily pass this needle through the bone and have our patients not react. So this is, people always ask, well, how do you know? It's going to take about 7 to 10 seconds. If you notice, we've got blanching in that approximately 4 or 5 millimeter circle. If you at stage 1 see blanching all the way down to the vestibule, you have given too much or not in the right place. So pressure and then pop. Now, right now, he's not holding that needle like a pen. That's on purpose just for this video, but I'll show you later that the way that we stay away from bending needles is we want to hold as close to that hub as possible. So at this point, we've changed pedals, and we're giving drop by drop anesthesia to this patient. Let's say we're treating teeth number S and T. This patient, I would give a quarter to a half a cart. This whole process takes about 2.5 minutes. I have seen some posts and doctors say, well, this just takes a long time. I will tell you that if you were to time giving a block and then waiting for your patient to get numb and then starting your procedure, the time is almost exactly the same. All right. Let's talk about angulation of our needle for this first stage. What I need everyone to know from this diagram, what we're actually looking at is that tooth is in the background, okay? So we're in the interseptal bone here. And that 45-degree angle that we talked about is based on the shape and the angulation of the cortical plate itself. We want to make sure that we are perpendicular to the cortical plate. As we get closer to the crest of that the alveolar bone, you see we have a little curve there, right? So that's where that 45-degree angle comes. Now, if we're in the anterior, I may be almost 90 degrees parallel to the bone. This is a very important slide. There have been, and we get questions all the time, and I know Chris gets questions and calls about this, worried about that needle passing through the tissue, through the plate, and then touching the permanent tooth. This is a 9 millimeter needle, okay? As you can see, you are not going to be anywhere close to developing tooth. Now, the rule is, and it should be for any injection in your office, that we're going to look at a radiograph. We're going to talk about that a little bit later here, but we want to take a radiograph, know where our developing tooth bud is. I want to make sure that I have appropriate bone, but you see at 9 millimeters, there is no way you're going to be, if you are close to that developing tooth bud way down there, we need to talk because we're not following direction whatsoever, but you're going to be safe giving this injection, okay? Whether you knew it or not, when you gave a standard infiltration, your local anesthetic was always working intraosseously, all right? So if we take our needle and we just give a standard infiltration, we're giving it superior to the periosteum, right? And we have to put a large bolus of local anesthetic superior for the periosteum and wait for that local anesthetic to travel through the Haversian canal and the Volkmann canals into that plate to get to our cancellous bone. The difference is we are going to bypass that now, right? We can actually use a smaller bolus of local anesthetic because we're going to pass the periosteum, we're going to bypass the cortical plate. And by giving our injection into the cancellous bone, what I want you to realize is now the flow is backwards to what is before. So again, this is not very different than what we've always been doing. You give that local infiltration and it takes a large bolus of local anesthetic or a larger, it's got to pass through the periosteum, through the cortical plate, into the cancellous bone, down to the apex of the tooth. This is like going to a fancy nightclub, right? We're going to remove that velvet rope, right? You're going to get right in. We're not having to wait to take that solution and pass through the cortical plate to get to the apex. We're going to deliver it as close as possible to the apex. So what it means is, in general, I'm using far less local anesthetic than I did before. The other thing that I want you to realize is once you're in past that cortical plate and you're in the cancellous bone, anything that is around the cancellous bone or attached to it is going to be profoundly numb. So that means that I do not need to give a backup palatal or lingual injection. Now, if there's an infection or some other situation going on, then I may do a backup injection, but I would say 95% of the time I'm giving one intraosseous injection and I can put my rubber dam on, I can put my clamp on the lingual, and I'm absolutely fine. So why do we need to give electronic delivery? What we need to understand is this is a metered dose. If you were to try to use this needle and just give a standard syringe and pop through the bone, the problem is you cannot give the anesthetic slow enough in order to not, number one, have too great of a pressure, but number two, not diffuse the local anesthetic over a large area. When we are, and I'll show you this in a minute, we are giving drop by drop delivery of the local anesthetic. If you think about if you had a dry sponge, this is allowing you to just give drop by drop local anesthetic, and we are keeping that bolus of local into the desired area and getting profound local anesthetic. If you try to do this by hand, you're going to give pressure that's way too great. Your patient will feel that. And number two, it's very difficult, almost impossible, to have that local delivery all in one area. It's going to perfuse far greater than what we need, and that means that patient will not be profoundly numb. What we need to understand is diffusion in general in the maxilla. Now, what I want everyone to remember, if you've seen this diagram before, these are permanent teeth here, okay? So if we give this injection intraosseously, and we call this osteocentral anesthesia, we're actually giving into that vessel. It's not going right at the septal bone. It's truly an intraosseous injection that's osteocentral. What we'll see is we're going to have profound local anesthesia bilaterally perfused. Okay, so this is omnidirectional flow. As you give that local, it's going to spread at least 2 teeth distal and 2 teeth mesial, maybe even 3. Again, permanent teeth, osteocentral local anesthesia. Now, the lower has a bias of flow. So at best, to give a full, at least full copy of local anesthetic, permanent dentition, I will get 1 tooth profoundly numb distally and at least 2 teeth, maybe 3 mesially. A little different with primary teeth, and I'll show you that. The concept here that I want everyone to understand is get rid of this idea of midlines. Midlines do not exist anymore. We can give that injection right at the midline and get both the central incisors on the right and the left numb. Why do we need to use a special needle here? These needles are different than the standard needle that you're using in your office. What I want you to see is the shape of this needle. It's shaped much more like a scalpel. And the key here is when we come in at the appropriate angle, we don't want to touch the periosteum at first, right? That's a great way. If your patient is having pain right away, it's because you're having pain, you're touching the periosteum. We want to use that needle where the D is facing out, and we're literally almost slipping that needle into the tissue, just superficial to the periosteum, and we numb the periosteum first. Again, the D's always got to be facing out. And remember, these needles, you've got to use the Epitech needles. Even if you try to get a different type of needle on, the unit's not designed for that. Now, here in the US, 99% of the time, we're using these 9mm 30 gauge needles for intraosseous delivery. What I do want you to understand is at 9mm, we are giving for a primary dentition, that is osteocentral anesthesia. We're actually able to, increase the amount of local we're giving, but at a 9mm needle for an adult patient or a teenager patient, let's say, or let's say all permanent dentition, we're probably only giving interseptal local. The important point here is you see where that doctor's holding the sleeper one. We've got to hold as close as you can to the hub. If you hold farther back, what's going to happen is you're going to bend needles. And everyone goes through this. You're going to bend needles at first, but I promise you, once you get practice, I rarely bend a needle these days. Don't worry about a needle breaking. I haven't seen it. Hypothetically, needle broke. It's in the bone. You grab your Howell pliers, you're going to take it out. If you're having a problem bending needles, watch your finger position, number one, and most importantly, you've got to hold close to the hub, just like you would for a pen, right? The approach is the other important thing. If you're having pain for that stage 1, you're likely coming on too steep of an angle. If you see the bevel there, what we want to do is just basically pick up the tissue, slide just superior to the periosteum, and deliver that local anesthetic right on top of the periosteum. So if you're having pain right away, it's coming from 2 things. Number 1, you're not delivering that stage 1 in the middle of the papillary triangle, or number 2, you may be touching the periosteum. Let's talk about the local anesthetics quickly here because this comes up a lot. Number 1, topical. You do not need topical, right? Some doctors use topical, it makes them feel better. I will tell you, you do not need topical anesthetic. So the 2 different local anesthetics that we use are articaine and lidocaine. I don't use lidocaine for these units. It's possible that you could. There's a few reasons why we use articaine. Really, my suggestion is, and all the KOLs and the doctors that use these devices quite a bit, really everybody's using articaine. So articaine in the US at least comes in 1 to 200,000 and 1 to 100,000. Majority of the time, I'm using 1 to 200,000 in my practice. Okay. The only time that I will switch to 1 to 100,000 is if I have a very infected tooth and I want to keep that bolus of local anesthetic as concentrated as possible. I'm going to use the 1 to 100,000. But vast majority of the time, I'm going to use the 1 to 200. The other thing is if you need a little bit more working time, you're going to switch to the 1 to 100,000. If you had to pick one, I would just use the 1 to 200,000 in your practice. And just make sure that your staff understands that they look a little different, right? So if you're using Septicane brand, one is silver and then the 1 to 100,000 is gold. All right. And again, we have lidocaine. You could use it for these units, but I really don't know many people that are doing that. And the volume of local that you need to give is far less than we did before. For many reasons, that's important. A lot of this is a pH issue, but just remember, if you're not having to give that large bolus of local anesthetic to bathe your IA nerve or perfuse through the bone, you need far less local anesthetic. And again, we use articaine for a number of reasons, but we do know that it's metabolized majority in the blood, so it breaks down faster. It's safer for us to use. Okay, so we have a 3-stage technique. Number 1, we're going to make the mucosa numb, just superior to the periosteum. Then we're going to pop through the bone. Then we're going to give our local anesthetic. If your very first injection, if you're right-handed, I would suggest that you use that you anesthetize S&T. So we're going to follow the rule of 1 tooth distal, 2 teeth mesial, profound anesthesia. An easy way to start this is, pick a patient that you need to do 2 restorations on S&T, and you're going to give 1 injection there. All right. You can be sure that with anywhere from a quarter or most likely a half carpule of 2% articaine with 1 to 200,000 epinephrine, that you're going to be profoundly numb from that canine back. Okay. I want everyone to really pay attention to this slide, because this is something Dr. Prin taught me, and I will tell you, if you're having pain in stage 1, likely what's happening is you're not entering the tissue at the correct location. So if we take that papillary triangle and we cut it in half, what I want you to realize is I don't want that needle to enter right in the middle of that papillary triangle. And the reason for that is once you advance, if you start in the middle, you may be close to the PDL of the adjacent tooth, and that PDL is highly innervated and you will have pain there. So I'm going to go, in this case, if I'm giving this injection S&T, I will go mesial to the middle of that papillary triangle. Here's the other key point that Dr. Prin taught me. Don't poke with these needles. They are so sharp that if you just put a little pressure, almost a bend, I promise you it will enter the tissue. If you poke or you try to push with these, number 1, it's not needed, but number 2, you are more likely to move far distally, more distal than needed, and you're going to get close to the PDL. So this stage 1 is giving this anesthetic drop by drop. There is no way that any of you are patient enough or have the manual dexterity to give this anesthetic drop by drop. So that's the small pedal, all right? And once our periosteum is numb, and I'll show you quickly here, we have a lot to go over tonight, but we're going to give you that stage 1. Do you see how they were about 15 degrees or so from the tissue, and they entered slightly mesial to that papillary triangle, and they're giving drop by drop anesthetic. Now, it's easy to get a little heavy-handed and advance that needle more distally, but don't. Get a good finger rest there, all right? For the manual bone penetration, we'll talk about that in a minute. What I want you to see here, these are the typical sites that we are giving this stage 1. Now, if you're going to remove canines, it's a different story, but pediatric IA block that we used to give, this is the new pediatric intraosseous injection for quote unquote IA, right? So we're going to give a quarter to a half a carpule of our anesthetic, and we're sure that if this is given properly in the right amount, canine and distal back to that primary first molar and second molar, you'll be numb. Now, if you only use the device for one thing, this is amazing. I used to give 3 or 4 injections to do this. And if you have that 3-year-old, there's nothing at least on my schedule, that I don't want to see is having to do for an awake child, composites or crowns or extractions on a young child without any type of sedation or anesthesia. You can literally give 1 injection, and if you give a half of carpule here to this patient, articaine 1 to 200,000, you will have profound anesthesia from canine to canine there. Now, if I was just going to extract the canines, I pooled everyone, all the people that I interviewed, and most of us are giving distal to the canine. I do want you to know that if there's an area that's a little difficult to get through, form follows function. We know those canine eminences are fairly thick. So if you're going to have a problem popping through the bone, I find often it's on the primary canines there. I promise you can get through. Just be patient. You may need to rotate your needle a little bit. So for that, For the manual bone penetration stage, if you can't pass through, don't just keep on putting pressure. Do gentle pressure, long axis of your device, and sometimes if you give it a little bit of a rotation, you'll be able to pop through. Okay, lower anterior region, same thing, canine to canine. All right, and this is this osteocentral anesthesia for children that we're talking about. This is actually delivering the local anesthetic. Now remember, it starts slow and then it speeds up. And I'll show you this from a different angle. So we're at 45 degrees here. You see the finger rest pressure, and then we pop through. And we're going to give a half to a quarter. That's really up to you, but I find anywhere from a quarter carp to a half carp. If the pulp's involved, if I'm extracting, I'm going to typically give a half a carpule. Now, everyone talks about the pop. You will not always feel a pop as you enter through that cortical plate. I find that if that patient is really 10 and under, you may have a slight resistance, but you may not feel the pop. Sometimes you do, but just know you don't have to feel a pop. Older children, of course, you're going to feel a pop because the bone is thicker, but really what I want to feel is actually to look to see if I am starting to have blanching immediately on the vestibule and the lingual. I probably am not through the bone. I may have been too horizontal and actually passed through the papilla. But if you have the correct orientation, after a few seconds and you wait, you're delivering enough local anesthetic, you are going to see, you may see blanching, or most of the time you should see blanching on the contralateral side. What I want to show you here with the review of anatomy is that the more apical you go here on the mandible, that cortical plate becomes thicker. But this is where we're entering, right? That trabeculated bone, and that's our containment vessel where our apex of our tooth is located, and we're going to be filling this vessel. If you fill that vessel, everything on the palatal or the lingual and the buccal will be numb. You should be able to do a pulp. You should be able to extract a tooth without issue. All right. Remember that once you get into that trabeculated bone, you just have C nerve fibers here. So your patients may feel pressure, but they will not feel pain. So if you have a child who's reacting a little bit, you can always come off the pedal for a second and then engage the pedal again. They're just feeling pressure there. Okay. Angulation of insertion. Remember, we want to be perpendicular to the osseous, to the cortical plate. So we're going to change our angulation depending on where we are in the mouth. Blanching. This is an important thing to know, is that if you have blanching in the vestibule, anything more than 4 or 5 millimeters, you're probably not in the bone. If you have a patient that you're finding that has a numb lip afterwards, you likely did not give an osteocentral injection. You may have delivered most, or if not all, of your local anesthetic more in the vestibule. I really do like to make sure, I don't always see it, and it's dependent on how much volume you give, but we want to see palatal or lingual blanching, and then we know that that entire area is fully numb. Okay. This slide, I think, is one of the most important here. So these are my 4 Ps. This is my mantra that I do literally every single time when I give an intraosseous injection. So as I come in the room, I sit down. Number 1, I want to make sure the unit's on. If it's been sitting for a little bit, that unit may be off. What I don't want to do is go to give stage 1 and then realize after I've entered the tissue that my unit's off. Ask me how I know. Once in a while, I'll forget. And I will tell you, it's not a fun day where you've got to come out and then turn the unit on and wait and then give your stage 1 again. So first things first, that first P, that's power. All right, is the unit on itself? Then the second P there is our actual procedure. I'm going to review the radiograph. I'm going to look at the bone. I'm going to choose my injection site. I want to double check, trust but verify. I want to make sure that the correct local anesthetic is in the unit. And then I'm going to go over all my tell, show, do. I may engage the parent, talk to them what I'm going to do. And then number 3 is the pedal. Before I go to start my injection, I want to make sure my pedal's in the right location. It's up to you whether you have on your right foot or your left foot, but you want to make sure you can easily engage all the buttons of the pedal. You don't want to start your first step and give your injection into the soft tissue and realize you can't find the pedal. Because if you try to move your foot around, you're going to advance your needle farther than you want. And so then the 4th is my position. right? I want to make sure the doctor's in the right position. I want to make sure the patient's in the right position. And I want to make sure my foot is in the right position. So power, plan, pedal, and position. You may want to take a screenshot or take a photo of this. I literally, every time I do one of these injections, I go through these 4 Ps and then I won't have a mistake. Let's talk about getting through the bone. As I mentioned, there may be some instances where that bone is thick in this area. You may need to rotate your unit a little bit. I promise you, in most instances, you'll get through, but you may find that you have to slightly rotate and then advance the needle. As you see, they were giving, although they were rotating, they were still putting pressure at the long axis of that sleeper one, and then they're able to penetrate the bone. If we let's talk about how much local anesthetic, because that comes up a lot. I know that Chris and Jordan and Aaron do get this question: is how much local do I give? Right. In general, if I want to make sure I have profound local anesthesia, if I have profound anesthesia from canine to canine here on a primary dentition, I'm going to give a half a carpule. Right. And again, one septicane, 1 to 200,000, unless I'm doing an extraction. I'm using the 1 to 200,000. Most of the time in this instance, I'm giving a half a carpule. I do want to see that vasoconstriction. You can see you've got nice blanching there on the facial. And if you get your mirror out and you look on the palatal, you should have vasoconstriction. You should see blanching there. Now, what do you do if you have a thick frenum? If you do have a thick frenum, you may need to go a little bit lateral to that frenum in order to pass your needle through. If you're passing through a large amount of tissue, it's possible to have tissue that is actually in your needle. And then when you go to deliver, you're going to see 4 lights on the sew end go right away, or it's possible to have a little bone in there. So you may go lateral to that. That's okay. As long as you pop through the bone, you're going to be fine. I think of it like when we first learned local anesthesia in dental school, they gave us orange, right? Once you pass your needle through the orange and you get to the inside, it doesn't matter where you enter that orange. If you're trying to numb the inside where the actual food is, you can enter anywhere around that orange and still be able to deliver your local aesthetic inside. It's the same thing here. You can go lateral to that papilla, and the lower arch, it's going to be the same way. So again, articaine 4%, 1 to 200,000, and I'm using, most of the time for this patient, if I'm doing 4 crowns, it's going to be a half a carpule. This is a patient I showed you earlier, and this was my shining moment where I realized I am never going to pick up a standard syringe if I don't have to again. So Bella was a very, very anxious patient. Mom was anxious. Mom actually was in tears when I told her, and the orthodontist told her that these teeth have been like this for a very long time. They're not going anywhere. And the orthodontist sent me a retraction referral and said that NOPQ needed to come out. Mom also did not want any conscious sedation for this patient. I said, okay, we're going to get through it, but I have a new way of numbing teeth and we're going to try it. Again, this was pretty early on. They wanted NOP to come out. In my hands previous to this, I would have given 3 to 4 injections, right? And if you have a patient that is already anxious, even with nitrous on board and a bunch of topical, I don't want to give 3 to 4 injections anymore. I gave 1 intraosseous injection right there at the midline, 1 to 200,000 epinephrine, and after I delivered that half a carpule, immediately needle came out and she was profoundly numb in all 4 of those teeth. Teeth were extracted. Everybody's happy. Actually, Mom was in the tears by the end of the appointment. I was in tears by the end of the appointment. I was sold. If you do nothing else, just use your devices for this. Now, I want you to use your devices for the entire mouth, but this is easy and it's just 1 injection. And I have 3-year-olds that we don't put topical on if I need to take out ENF, and they literally don't react. So the most basic, besides the anterior, is this pediatric IOA. So what are we going to do? We're going to use a 9mm green needle, and that anesthetic, remember, for a child, they were truly giving osteocentral local anesthesia. Now, in the anterior, we give up to 6 teeth, but remember, we're going to give, on the lower here, 1 tooth distal and 2 teeth mesial will have profound anesthesia. And you're going to use, again, most of the time, that 1 to 200,000 epinephrine for your 4% articaine. All right. This is all in your manual, but this is, again, probably one of the most common places that we're going to give this injection. Now, One thing to remember is that depending on if I'm only treating S&T and I'm doing, let's say, back-to-back composites there, I feel comfortable giving a half a carpule of local anesthetic. Now, if I'm going to be in the pulp, I need to make sure that I'm going to give probably a half a carpule of local anesthetic. I'm also going to take my mirror and make sure that I have blanching on the lingual. In pediatric dentistry, when we look at our radiographs for bite wings and PAs, honestly, most of the time we're looking for caries, right? Caries, yes, caries, no. You need to start looking at levels of bone. Do I have enough bone in that area where I want to inject in order to be able to give that intraosseous injection? Okay, so this is standard, run of the mill. We're going to give a half a carpule of articaine. You see, we're in stage 2 there. We're going to deliver that half a carpule. As soon as that needle comes out, that patient is ready to have treatment. We've got to make sure that we review our panos or our PAs. I've got a good level of bone here, right? There's no infection. I can kind of pick my spot. I'm not going to have an issue. And I can easily give, if I need to make sure I have profound anesthesia on the 6th area, the adult first molar, I'm going to give probably a half a carpule of local anesthetic, and that whole area here in blue will be numb. Watch your panos. You've got to look for levels of bone. I showed you this already. Everyone should be familiar. This is a great introductory video for your teams, just to show them what intraosseous anesthesia looks like. Thank you, Paul. This is one of the best videos that we have out there. Now, what do we do with infected teeth? Number one, we're going to take a radiograph. Got to make sure that we have sufficient bone. If you look at K and L there's an infection brewing that may not be between K and L be a great place to give that local anesthetic. I need to go distal to K. Absolutely fine. Now, I may want to back that up with another injection mesial to L there. That's okay. But again, look at your radiograph, see where your level of bone is. There may not be great bone between those two teeth. And if you have a problem getting profound anesthesia, it's possible because of that infection, that area is becoming marsupialized. There's not good level of bone there. You may have an issue. So we're going to go distal too. Totally fine. With teens, remember that with a 9mm needle, you are not going to get osteocentral an injection of your local anesthetic here. This is intraseptal. You're going to give at 9mm, you're going to get one tooth mesial and one tooth distal. I've seen some posts where people said, well, I had a teenager, they were 15, I was able to pop through the bone, but I got the rubber dam on and I tried to treat a couple teeth and I didn't have profound anesthesia everywhere. Well, that's to be expected. One mesial, one distal, at least a half a carpule there. That's pretty much all you're going to get. You look how far that apex is, it's far with a 9mm needle, right? Pick the area where the bone is sufficient. And if you have to think twice, you can give it in a second area in that quadrant. Not an issue, plenty of bone there. That gets to be a little bit more difficult. Remember, we may have a canine in the area. We're going to look at our radiographs. What about odontomas? Probably not. This may be an issue trying to get local anesthesia there for that canine. Look at your radiographs. The reminder here is we're not just looking for caries anymore. We're going to look at our level of bone, and this is those 4 Ps. I need you to plan where you're going to enter with your needle. Sinus tract. We've got to take out this primary second molar. In my hands, I'm going to give 2 different sites here, right? I'm going to inject mesial to that primary second molar and distal to that primary second molar. I'll probably give, maybe even a full carpule of local anesthesia here, local anesthetic, but I know I'll be profoundly numb. I've got to pick a site where there's not that active infection. Palatal. Before I started giving intraosseous local anesthesia, you could not convince me I'd ever give a palatal injection again. Now, these palatal injections are very different than what we learned in dental school, where you're just numbing into the soft palate. And I want to thank Eric Hans, who reminded me about this, is if I'm right-handed and I've got to give an injection for I and J, sometimes it's a little difficult to get proper hand placement. If you remember, the cortical plate is thinner on the palate, and I will use the palatal site all the time. I promise you, it works well. It doesn't hurt. I wrote, don't be a baby. I got a little punchy there. I promise you, you may worry a little bit because you haven't given a palatal injection for a long time. But especially if you have a big infection on the buccal there, and there's a polymorphous between the 2 teeth, and you've got nice bone there on the lingual, go ahead and give a palatal. Again, this is another example of where the magic happens with these units. Molar hypoplasia. We know that you don't even need to show you studies on these. These teeth are extremely difficult to get profound local anesthetic. And these restorations are difficult enough. So if I already have a patient that I can get through half of my handpiece and I have to keep on stopping, give a block or give a local infiltration, it makes that procedure much more difficult. With intraosseous local anesthesia, these teeth are profoundly numb. There you go, 25% for infiltration, and this study found 88%. In my hands, it's almost 100%. Now, sometimes they may give part of that injection on the mesial of the tooth and part on the distal, but you will almost certainly get profound anesthesia here. One thing to remember is that with partially erupted teeth, let's say you're treating a number 31 when it's halfway erupted, it's actually easier to pass through the cortical plate when that tooth is not fully erupted. Before I had the ability to give an intraosseous injection, it was hit or miss if these patients would get numb. And I'll tell you now, those are some of the easiest injections to give because the bone cortical plate's not thick. At that point, you've got a partially erupted tooth. What I do want to remind you, though, is if you still have a little bit of papilla that's covering that tooth, you may need to back up a second injection into that little finger of tissue if you're going to do a gingivectomy there. Because it's not over attached, that tissue is not attached, I can't guarantee you that it's going to be numb, but that's okay. Go ahead and give your intraosseous injection, finish whatever local anesthetic you're going to use and give that bolus, then stop, and you may want to back up and give a couple drops into that remaining tissue just to make sure that you have proper anesthesia and you have proper delivery of your local both in the tooth and the soft tissue. I just cannot thank the Dental High Tech enough for these devices because these can be difficult restorations, right? And sometimes we're treating patients that are not the happiest to be at the dentist. And if I can take away the worry that I've got a hypoplastic tooth that is not numb, my life gets to be a lot easier. Now, here's an exception to the rule. If you already have an active infection, that system may be pressurized, right? If we see, and you may not see bone loss in the PA, but if you see a big parulus, I don't care how careful you are with your stage 1, there may be some pain associated with this if you've got a large active infection. So this is an example of where I may change my button, right? I may step on my pedal and go and change the mode to pink, and I may give a little bit of a standard infiltration in this area and then back it up with an IO. Again, more pressure. If you add pressure to the system, you may have some pain. Now, no matter what, your patient may feel a little bit of pressure on that IO, but at least they won't have any pain associated with it. And I promise you, you try to do this with a standard syringe, there's no way you can deliver that 1 milliliter per minute. That's what we all should be delivering, right? It's about 1 milliliter per minute. And I have had some docs post, they said, well, I could just do this with a standard syringe. There's nobody out there, very few of us, that have the patience or the dexterity to actually give the local anesthetic that slowly. So let's go to some frequently asked questions that we come up on our Facebook group. So why is the local still coming out of the syringe while I'm not pressing the pedal? There may be an issue with cruiser drive mode. I want to make sure by the end of this, everybody understands the differences, right? One point that I want to make here is even at stage 1, you have to remember as you're injecting, you're building up some back pressure there. So once you give that initial stage, wait a few seconds. Okay? That's when my system knows to flip on the suction. So as I enter the tissue, I'm going to deliver my 5 to 10 seconds of stage 1, and then I will wait just a few seconds before I remove the needle, and then my assistant will flip on their high-speed their suction, and I know that I'm not going to have drops of local anesthetic. It doesn't taste very good in the patient's mouth. How do they communicate? So these are radio frequency, right? There's no batteries. Someone posted something earlier this week about how you change the battery. There's not a battery in your pedal. Right? Why don't I feel the pop? Again, you're not going to feel the pop every single time. I would say if it's under 10 years of age, it's going to be hit or miss if you feel the pop. 10 and above, you're likely going to feel it, but it doesn't mean that you're not in the right area. I don't have buccal bone. There's a big abscess or parulus. What do I do? Again, you need to find where you have good bone. So you may move a little bit mesial. You may move a little bit, one tooth mesial, one tooth distal, or a half tooth mesial, half tooth distal, or don't forget about the palate. I was pressing the pedal, but the light was not blinking on the unit. One important point here is I want to make is you need to make sure that you're actually have the right pedal. There are some talks that if you have a psoan, multiple psoans, you may want to label them to make sure you have the right pedal. And again, make sure that your foot is touching the right button. The small button's always going to win. So if it's taking time or that blinking is slower than you expected, you're likely stepping on both buttons. All right. I finished a carpal in the unit reset and I still in bone. Is that aspirating? Is that bad? No. Totally normal. It's as that unit resets and the plunger comes back. If it aspirates a little bit, it's absolutely fine. Remember, for intraosseous injection, we're not doing that aspiration step. You're only going to do that with a block. And these units, if you press the correct corresponding button on your pedal, you will be able to aspirate after you give about 1/8 of a carpule. Okay. Post-operatively, what can happen? Very, very rarely can you see some localized tissue necrosis. The only time that I've seen that is, I believe what happened is they were using articaine at 1 to 100,000, and they were not giving osteocentral injection. They actually delivered half a carpule into the papillary triangle, and they had a little necrosis afterwards. Okay. Yes, if you give too much local in a site, just like you would for any standard injection, you can have some soreness afterwards. I can't remember a parent telling me their child was sore afterwards. And sometimes it's just from the dental treatment itself. All right. What are the reasons that the local anesthetic won't flow and the lights? Again, are there needle in the right spot? Are we have our needle up against bone? Is there some obstruction? Or, if I'm giving that first stage and I see lights come on right away, you should not see any resistance there. That's first stage. You may be up against the PDL or the adjacent tooth. And what do? Back out. An important point here about a new needle. These needles really, per quadrant, you want to use a new one. Now, if it's a little child, you may not need to switch the needle, but just by habit, I switch my injection site, I grab a new needle every single time. Because they're so sharp that once you pass through bone, that needle is going to deform the edge. Just grab a new needle. They're not expensive. All right. And buccal, lingual, doesn't matter. You can pass through. Okay. You can aspirate. We talked about all these things. Can you give regular injections? Yes, you can. Great. If you still want to give blocks, go for it. I don't see the need for it in my practice, but go for it. You can. If you don't do anything else, just change your needles. All right. So dental anesthesia has evolved, right? We're no longer using our standard syringe. I really believe that this should be the standard of care. I want everyone to feel comfortable with these units. I want you to get return of investment. You will get it both in saving time and having happy parents and happy patients. And once you decide to just say, you know what, I'm done with the regular syringe, I promise you'll easily adapt these in your practice. And if you have issues, you want to reach out for help. And there's lots of help out there. So I want to thank NuSmile. I want to thank Dental High Tech for allowing me to be involved. The more that I get to talk about these units, the more I learn, the better clinician I get to be. And I get to spend time with all of you. Remember, if you have questions, there's lots of help out there. Talk to Chris, talk to Jordan, talk to Aaron, join the Facebook group. Importantly, there are some workshops coming up. The Restore workshop with NuSmile, you can go on NuSmile's website and see where you can demo these units and learn all about all the other products that NuSmile makes. And thank you so much. For those of you that it's late at night, can you go to bed? I know it's late, but I appreciate all of you that stayed on, especially on the East Coast. And I will turn it back over to Chris right on time.
Awesome. Thank you, Dr. Solomon. Very thorough. Really appreciate it. So thorough that we only have 4 questions. So
Perfect.
let's see what we got here. Let's start with a good one. I have a just barely 2-year-old who will need D and G extracted
Mhm.
due to ECC. Would you feel comfortable using septo and IO technique?
I knew that question was going to come up. Okay, so if you look at the package insert for Septicane, it's going to say 4 years and above. Okay, this is not NuSmile Dental high tech talking. This is me talking. Um, if you listen to any of the podcasts or information from Malamed, he'll tell you that they didn't do testing on children 4 and below with Septicane because there's not many parents that want to volunteer their child who's 3 or 2 for testing. You have that DR in front of your name. What the FDA, when it does, when it clears a drug that's safe to use, um, you have license to use that drug as you wish, right? Myself, everyone else that uses these units on a daily basis does not have a problem utilizing Septicane for children under 4. Okay? I do not have a problem with it. And you can do your own research. You do what you feel comfortable, but I would give for that patient, I would give probably a half a carpule of 4% lidocaine, or you could even use the 100,000. But if I want to really make sure I've got good perfusion, I'm going to use in that case likely the one to 200,000. I'll give a half a carpule. I have no problem extracting those teeth.
Awesome, thank you. How are you mounting the SOAN in your operatory? Do you use the charger as the quote unquote mount?
Correct. So it lives on the charger and then it gets wiped off, ready to use. And then when I go to pick it up, it's actually sitting on the charger and I know it's cleaned. They already have the needle on. And then when I'm done using it, it goes back on the operatory tray. And then my assistants will turn it over, clean it, change the needle and the cartridge for the next patient.
When injecting intraosseous, how does it feel? Sometimes I will feel the needle dip and sometimes I don't. Do we use the hub of the needle as a reference?
So I think what the doctor is saying is number one, you don't want to bury your needle, right? So this you want to leave that needle, a few millimeters just shy of the soft tissue. One thing I think is really good to experiment to feel the pop. Actually, if you take a cardboard box similar to this and you pass that needle through, I think it's very similar. You'll feel that initial pop and then a drag. Um, we found this one day actually in Toronto. We were just playing around, and I was putting the needle through a cardboard box like this, and I thought that really feels like the pop. So try that when you're practicing. I think it's very similar.
I have been using SOAN for 1 week. Love it. I have had a few cases where the Epitech needles bend when I'm trying to go
Great question.
intraosseous. Please discuss ways to decrease needle bending. Thank you.
So did I. I bent. I'm not a small guy, and I have not a lot of patience sometimes. And I bent a fair amount of needles when I first started. Now I can tell you, I don't remember the last time I bent a needle. So here's what we need to do. Think about your 1 point versus 2 point fulcrum. If you grab your unit and you're holding it with a pen grip and you have your fingers right at that hub and you're giving directed forces down the long axis of your unit, the chances of you bending a needle are very low. Typically, it comes from grasping too high up, so too far away from the hub, and then torquing your hand one way or the other. So again, close hold. I mean, if I could, I would actually hold on to the needle itself, right? So you're going to hold on the base of that hub, directed forces. What I don't want you to do is poke. As you enter, you get ready to pass through the soft tissue and you hit periosteum. Don't just put pressure on right away. It's slow pressure. Just barely increase that pressure, direct force over time. If you have to, you rotate a little bit, you pop through. Everybody worries about this at first, but I promise you, after you use these devices enough, you'll be able to pop through the tissue. You will not bend needles.
Can you
Oh,
touch on anesthetizing permanent dentition a bit more?
yeah, great question.
I feel that my injections for deep caries on 6-year molars does not give me a consistent result.
Okay, so we have to remember the difference between interseptal and osteocentral delivery of local anesthesia, right? So the older the patient is, you have to realize that 9 millimeter needle is much farther away from the apex of a permanent molar than it is from the primary molar. I would say that number one, we need to make sure that we're actually, into the cancellous bone. You may, if you feel like that you're not getting profound anesthesia, think about giving even distal to that molar, right? I think the go-to area is always, well, the mesial of the 6. Let's say you're injecting for number 30, you're just going to give it the mesial. You can still give it to the distal. And if you're having a problem, give a quarter carp or half carp on the mesial and back up with a quarter carp on the distal. And I'll find there's very few times where I don't get profound local anesthesia, especially on hypoplastic molars. And remember, it's a permanent dentition. If you have a patient, let's say, you want to numb both bicuspids, you're going to get bicuspids numb, but it's not always 100%. Let's say the molar, the canine, that you're going to get profound local anesthetic for it. Again, that is interseptal versus osteocentral.
All right, we got a question. You ready?
Ready.
Do you prefer to give the injection prior to placing the isolite or while it's in?
Yeah, that's a great question. I like to place the isolite and then give the injection. There's really no reason why not to. I've got great isolation. The lighting's great. I know that my chance of my patient tasting anything is slim to none. And especially because if we're going to, instead of giving a block and then waiting, put the isolite in, go ahead and give your IO and you start treatment right away. So I will put my isolite in first and then give the local. It's you have to remember to do that because we're not used to doing that, but that's one of the my favorite things to do with these units.
Awesome. Last thing is just a reminder about the Restore workshops that we have those scheduled throughout the next couple of months. And then upcoming webinars, we'll start advertising for those next week, but we have 2 as well in the month of February, February 12th, and then at the end of the month. So typically they're 2 weeks apart. I can't think of the date right now, but typically 2 weeks apart. Restore workshops give you a hands-on opportunity to actually get the device in your hand, practice with it, use it on chicken bones. You can thank Jordan and Aaron for their time spent deboning and de-meating chicken bones for those workshops. But they're great events. So hopefully we'll see you at one of those in Chicago or Charleston. Unfortunately, I believe Pearls is sold out. But if you are already going to Pearls, you'll see Aaron there. If not, we'll catch you at the next one. We do have one more question.
Please.
I had an IO anesthesia not with your system. It was great, as I always have a hard time getting numb in the mandible. However, the post-injection pain lasted for a while. Is it different for kids due to the density of the bone?
We covered this, at the very beginning. If you're using any other device, they are not designed specifically to give intraosseous local anesthesia. They don't have the algorithm. They are not monitoring. If you're so in particular, that's measuring the pressure, hundreds and hundreds and hundreds of times a minute. And I'm not surprised you had pain because you're using a device that's not designed to give intraosseous local anesthesia. You probably gave way too much pressure. Maybe the volume was too high, and that's to be expected.
Yep, that computer-assisted algorithm helps deliver that solution at the appropriate speed.
Electronically mediated delivery.